Sorry.
Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Sami, 55 years old, has vomiting since yesterday. Please take history, examine the patient, and address his concerns. Are you ready?
Yes.
Okay, here you go.
Hello, I'm Dr. Mitwalli. I'm the medical doctor in the clinic today. Let me
Yeah.
confirm you are Mr. Sami, 55 years old.
Yes, doctor, I'm Sami.
Nice to meet you, Mr. Sami.
Nice
Mr.
to
Sami,
meet
we are here today to discuss about your condition. Is that all right?
you. Sure, doctor.
So, can you tell me more about your condition?
Yes, doctor, I have been complaining from throwing up since yesterday. Since it started, it is progressive and increasing. I can't eat anything, doctor.
And it started only yesterday?
Yes, doctor. Since
How many
yesterday
times?
only. Around 5 times or 6. Yes.
Yeah, this throwing up, it's like large amount or
I didn't know, doctor.
is it
Maybe
mixed with food particles or is it like watery?
just watery, doctor. I can't eat anything.
I'm sorry for this, Mr. Sami.
Thank you, doctor.
Mr. Sami, did you notice any blood in the vomiting, in the throwing up?
No, doctor.
Okay, Mr. Sami. Mr. Sami, do you have any history of long-standing disease I should be aware?
Yes, doctor. I have a type of cancer.
What's this, doctor? What's this cancer?
I don't know, doctor. I think
Okay.
non-Hodgkin lymphoma, like that.
Are you taking any treatment for this cancer?
Yes, doctor. I will.
Since when you were diagnosed?
Since 2 months. I started treatment since 2 months.
2 months. Okay, and you are taking the treatment currently?
Yes, doctor.
Okay, Mr. Sami. Apart from this cancer, do you have any other medical condition I should be aware?
No, doctor.
Okay, and apart from the treatment for the cancer, are you taking any other medicines or medications?
No, doctor. No.
Okay, Mr. Sami.
Medication in the chat box.
Okay.
Mhm.
Okay, Mr. Sami. Okay. Okay. Mr. Sami, do you have any headaches?
No, doctor.
Any visual disturbance like blurred vision
No.
or double vision?
No.
Okay. Do you have any weakness in any part of your body?
No.
Did you notice any abnormal sensation in any parts of your body?
No, doctor.
Okay, Mr. Sami. Mr. Sami, any shaking in your body?
Shaking, no.
Okay. Do you have any tummy pain?
Yes.
Where
Yes, doctor.
exactly?
I have tummy pain. It started since yesterday also. I think it is in the upper tummy.
In the upper tummy.
Yes.
Okay. Can you describe this pain? It's like dull aching or like burning pain or?
Yes, doctor. It's dull aching pain.
Okay. Can you grade this pain like from 1 to 10, where 1 is the minimum and 10 is the maximum?
Yes, doctor. From 4 to 5.
Okay, Mr. Sam, did you notice this pain is traveling anywhere like to your back or other part of the body?
No, doctor. I don't think so.
Okay. Do you have any loose motions?
Loose motion? No.
Do you have any hard motions or constipation?
No.
Okay. Did you notice any change in your eye white, like you lose discoloration of the eye?
No.
Okay, Mr. Sami. Mr. Sami, do you have any dizzy spells?
I think, doctor, since yesterday, I am not good. I feel tired. I can't stand from the chair.
Do you feel dizzy when you stand from sitting position or?
No, doctor.
Okay, Mr. Sami. Mr. Sami, do you have any history of loss of consciousness?
No.
Okay. Okay, so okay. Do you have any joint pain?
No, doctor.
Any skin rash?
Skin rash, no.
Do you have any cough?
No,
Any chest pain?
no, doctor.
Okay. Do you have any racing of your heart?
No,
Okay. Did you feel any lumps or bumps in your body?
yes, doctor.
Yes, this is
Yes,
from your cancer.
yes, doctor. It started since 4 months.
Okay, Mr. Sami. Okay. Do you have any family history of cancer or long-standing disease or disease of note?
Yes, doctor. My father has had a stroke. Sorry, my father has prostate cancer, and my mother have hepatocellular carcinoma.
Okay, Mr. Sami. Okay. Do you have any recent history of travel?
No, doctor.
Okay. Are you taking your medicine on a regular basis?
Yes, doctor. Yes.
Okay. Did you miss any medicine?
No.
Okay. Do you have any recent illness like fever or sorry, high temperature or flu
No.
symptoms?
No, doctor. No.
Okay. Okay. Can I ask you what do you do for living?
Yes, doctor. I am a teacher.
And how much your symptoms affect your job?
Yes, doctor. It affected me a lot.
Yeah, I'm sorry for this, Mr. Samuel. I hope we can help you regarding this.
Thank you, doctor.
Do you smoke?
Yes, doctor.
How many cigarettes per day?
5 cigarettes per day
Uh, For how long?
for 30 years.
Yeah, Mr. Samuel, although this small amount, but also smoking is not good for your health and also for your condition. So I advise you to stop smoking. If you need help, we can support you by referring you to smoking cessation clinic if you don't mind.
Okay, doctor. Thank you. I will think about that. Thanks.
Do you drink alcohol?
No, doctor.
Okay, Mr. Samuel. Can I examine you?
Sure, doctor.
Okay, I will start my examination by checking the hands, okay, for
Mhm.
any hyperpigmentation, okay, for the palmar creases.
Is it not? It is normal.
Okay, I will check also for clapping, okay.
Normal. No clapping.
Okay, I will check the power of both hand by barometer drift. I will ask him to elevate both hand to check
Yes,
for any weakness.
yes, doctor. No, normal.
Okay, I will check the pulse. Okay, I will ask for the observation chart for his pulse and the blood pressure.
Yes, yes, doctor. Pulse is 70 and the blood pressure 170. 110.
Yeah,
110 70 blood pressure.
okay. I'll check also blood pressure sitting and standing. If
No
there is any
need.
postural drop.
No need, doctor.
Okay, I will check skin turgor. Okay, for signs of dehydration.
Yes, it is positive.
Okay, then I will check his eye for pallor. Okay, and jaundice.
Yes, it is pallor.
There is pallor.
Mhm.
Okay, I will check his oral mouth for the oral mucosa also for hyperpigmentation.
No hyperpigmentation, no cyanosis.
Okay,
Mhm.
then I will check his lymph node. I think he has also lymphadenopathy.
Yes, he has lymphadenopathy.
Okay. Mr. Sami, did you notice you cannot tolerate hot weather or cold weather?
No, doctor, I don't think so.
Okay, did you notice change in your body weight?
Yes, doctor, I'm losing weight.
Okay, Mr. Sami.
Mhm.
Then I will do abdominal examination. I will do superficial palpation, okay, to check for any palpable masses. Then and also for tenderness. Then I will check, do deep palpation and check for hepatomegaly and splenomegaly.
Okay, doctor,
Okay.
there is splenomegaly.
Okay.
Mhm. No hepatomegaly, no ascites.
Okay. Then I will check. I will auscultate the bowel for like weak bowel sounds or hyperactive bowel sounds.
Normal.
Okay. Okay, Mr. Sami, did you eat like in local restaurants or outside restaurants the previous days?
No, doctor, never.
Okay, Mr. Sami. Mhm. Okay, so okay. Can I know? I need also to do fundus examination to check for any papilledema.
Yes, doctor, no need.
Okay. So can I know what's your concern, Mr. Sami?
Yes, doctor, what I have, is it another cancer?
I appreciate your concern, Mr. Sami. So from our discussion today, new cancer is not a possibility. Okay, but we have also to exclude this. Okay, we have multiple causes of your condition. One of these causes that you may have a deficiency in a hormone called cortisol, which causing this tummy pain and dizziness and repeated vomiting that you had. And also the other probable causes, maybe you have like inflammation in your soreness in your gut that causing this repeated throwing up. So what we are going to do, we need to admit you to the hospital. Okay, we will give you fluid through a needle because also you have dehydration, so we need to give you fluid through a needle. We will run some blood tests to confirm our diagnosis, and we may need to give you replacement for this hormone, which is cortisol. And when we confirm our diagnosis, we will come back to you to discuss the further management plan that we can give to you. Is that okay?
Yes, doctor. Do you admit me in the hospital? Do you will admit me?
Yeah, we need to admit you to
2
the
minutes
hospital.
left.
We need to admit you to the hospital and to give you also the proper treatment.
Okay, doctor. Thank you very much.
Mr. Sami, do you drive?
Yes, doctor.
I advise you also to stop driving because of this dizziness that you have. Okay, until we correct this problem, then we will assess you later if you can resume driving or not.
Okay, doctor. Thank you very much.
Okay, Mr. Sami.
Thank you, doctor.
Okay, you want to examine something else, Dr. Ala? The buccal cavity in
I
the hand.
examined the buccal cavity, I examined the hand for the palmar creases for hyperpigmentation.
Okay, enough. You
And the
did it,
buccal
perfect.
cavity.
Okay, good.
Mm.
Okay, so you're satisfied. Let's go to the examiner question. Dr. Mahmoud, you can start.
Yes, doctor. Please present to me your case and give me your differential diagnosis.
So today I examined Mr. Sami, who is 55 years old. He was complaining of acute onset of recurrent vomiting since yesterday, associated with dizziness and tummy pain. He had a history of non-Hodgkin's lymphoma, for which he started treatment recently. including also prednisolone. During the examination, I cannot appreciate any positive findings apart from the findings of his lymphoma with lymphadenopathy and splenomegaly. There is no signs of intestinal obstruction. He has also signs of dehydration. Okay, so my first differential, it can be adrenal crisis, either from metastasis or from the prednisolone. But he didn't mention like he skipped prednisolone doses.
Okay, doctor. Anything else?
The other differential could be gastritis.
Mhm.
Okay, but also no history of that of recent like food outside restaurant. The other history could be also intestinal obstruction or gastric outlet obstruction.
Mhm.
Okay, on my bottom differential can be space occupying lesion of the brain, but against this, there is no any signs of weakness. There is no visual disturbances. Okay, there is no any other signs of apart from this vomiting.
Mhm. Okay, doctor. What else?
In the differential,
Mhm.
it could be.
Okay, doctor, you think this patient you will admit here in the hospital?
Yeah, if we are suspecting adrenal crisis, he should be admitted to the hospital. We need to check his blood cortisol level, and we need to give to do. He is like it will be like emergency. We need to do ABC and to give him fluid resuscitation and the corticosteroid replacement.
Mhm. Okay, doctor. Okay. What is the urine in this patient? The frequency of urine?
No, I didn't ask about it.
Okay. Does the patient has fever?
Yeah, I asked about high temperature.
I think no.
I think I
No,
asked, do you have?
he asked, yes.
Yeah.
Mhm. Okay. Okay. This patient was in chemotherapy. So when was the last session?
Yeah, I didn't ask the last session, but I asked that he's taken recently. He's in current.
Okay, Dr. Alaa. Okay, what else? Do you have any other differential diagnosis?
No, I don't have other differential.
Okay, she has decreased urine output. So what will be you will be
So if in this condition we can suspect acute kidney injury,
yes,
like uremia, maybe the cause of vomiting.
yes. Anything else other than uremia?
No.
Okay,
I don't
doctor.
have.
Okay. What about her medication? Can be cause vomiting?
Oh, I don't know exactly.
Okay, Dr. Alaa. Thank you.
Okay, you're done with the questions?
Yes, I done, doctor.
Okay, any investigation you want to add, Dr. Alaa?
Yeah, we'll do basic blood test. We'll do CPC. We'll do serum electrolytes. Okay, to check for the electrolytes from this vomiting. We'll do kidney function test. If we are suspecting adrenal crisis, we can do random blood cortisol level. We can also do blood sugar. Okay. And maybe also 24-hour urinary cortisol and ACTH level. Then I think this is the investigations. We can do also a high resolution CT of the adrenals and the MRI.
Okay, if you suspect the drug induce, what we should add?
Drug level,
Yeah,
okay,
okay.
we can check, yeah, the drug level.
Okay, any image to the abdomen?
Yeah, we can do CT abdomen with, if we are suspecting in obstruction, we can do CT abdomen with IV and oral contrast. If we are suspecting the adrenal, we can do high resolution CT or MRI adrenal.
Okay, thank you. Fair enough. Dr. Mahmoud, you can comment now.
Yes, well done, Dr. Alaa. This case came since 1 year in Egypt, in Cairo. This patient, 55 years old, has non-Hodgkin lymphoma. Outside the room, it was patient 55 vomiting with increased kidney function. This is in the paper. So when inside, patient has vomiting and little upper abdominal pain, grade 4, dull aching. Patient was, the comment of the examiner was, when was the last session? Last session was since 2 days. Okay, so we have and decrease the urine output, decrease the frequency and the amount. So my first diagnosis will be tumor lysis syndrome or drug-induced vomiting or drug-induced kidney failure and kidney failure-induced vomiting. That is different diagnosis. About the history, Dr. Alaa didn't ask about the urine output. I write here didn't ask about B symptoms. You asked only about weight changes, but you didn't ask about fever. You didn't ask about fever.
Night sweat.
Night sweat, yes, you didn't ask. You didn't. I think in the history, you didn't ask me more about the abdomen, but the patient has abdominal pain and vomiting. I think you didn't ask me a lot about the abdomen. Also, we have to assess the chemotherapy medication because the doxorubicin has cardiac toxicity, so we should examine the lower limb for any lower limb edema, any cardiomyopathy in this patient. And about the medication, you didn't ask me when was the last session. So the case will be tumor lysis syndrome. You should do all electrolyte, potassium, phosphorus, uric acid. All of this electrolyte will be increased, and the only decreased will be calcium. And also investigation, you will do basic all electrolyte, ABG, uric acid, ultrasound, kidney to exclude any obstruction for fear of renal cell carcinoma. Examination, you will examine the pulse and blood pressure and GVB. If there is any volume overload, also to check the heart for any pericardial rub. Also check the base of the lung for any pulmonary edema. Also check sacral the edema in the lower limb. And the abdomen, you will check the kidney because the patient has decreased urine output. So you will do a ballotment of the kidney. Treatment of tumor lysis syndrome will be admission of the patient and give him IV fluid and plasmapheresis. Okay, that is my case. This case was discussed in the group, I think, with Dr. Basim since a long time. Hello?
Yes, I remember it. Yes, I remember it.
Yes, I discussed with you, Dr. Basim, since a long time.
Yeah.
But because Alaa will enter Cairo exam, I wanted to
pay his
give
attention.
to him.
Yes.
Yes, because it is maybe come again.
Yes, sure. It's a common case in
Yes.
Cairo, and he should be ready for this kind of question or the other kind also of cases. Rhabdomyolysis related also to
Yes,
acute
rhabdomyolysis.
presentation. Yeah, it came in Egypt also. So both scenarios comes as acute presentation or acute cases due to kidney failure because of primary reason, which is either here the cancer, and in the other scenario would be muscle injury after long-term exercise or heavy exercise.
Mm.
You finish your comment, Dr. Mahmoud?
Yes, Doctor. Yes, Dr. Bassem.
Yeah.
I finished.
So my comment to Dr. Ala, if you miss one system, you might miss the case. Again, I think previously also you miss one system in the systemic review, and it was also difficult to pick up the case. Why? Because you're asking questions from here and there. I think you was or you were wondering when he give you a case or the history of non-Hodgkin lymphoma, so you don't know what to do, or you didn't know what to do. You are lost, or you're being lost, right, Dr. Ala? I think when he gave you the history of the
No, when he gave me the
non-Hodgkin
history of vomiting.
vomiting.
Yeah, he gave me the history of vomiting.
Take it easy. Take it easy. Okay,
I
I will
think-
tell you
I
how to
think-
do.
I
Yes,
started to
I
search
think
everywhere.
this is a problem of every one of us. When you
No,
put
no,
a
it's not problem.
diagnosis,
By the way,
No,
it's very
Dr.
easy.
Bassem, yes, when you put a diagnosis in your mind, Alaa put Addison in his mind. So
Exactly, and he went through all question for
Yes,
Addison, and he put it as
all-
differential.
yes,
Yes, exactly.
all intention about his
Yes, yes. But I will tell you how to do it, Dr. Ala, easily. Whenever you have a complaint, do it as regular. Onset, course, duration, timing, what increase, what decrease. That's it. If you finish, follow your approach easily. Continue your approach. Any constitutional symptoms? Yes, there is constitutional symptoms in this scenario, which is the non-Hodgkin lymphoma. Of course, there is loss of weight, loss of appetite, loss of or night sweat and night body temperature or high body temperature. Then continue your systemic review easily. The relevant system, we missed the relevant system. So after the onset course duration analysis of the relevant system, here the GI. I think you asked the about the eye question, but you miss some questions. Okay, let's start from the mouth. Easily from the mouth. Any soreness in the mouth? What do you think the importance of the soreness of the mouth or mouth sores? Is it important in this scenario, Dr. Ala?
Mouse source.
Yes.
I don't know, inflammatory bowel disease or
If you have patient with cancer and he's on immunosuppressive medication,
immunocompromised,
yeah,
fungal
so
infection or
exactly, you might have HIV and he will have either HIV or any fungal infection. It will lead him to be dysphagic or having dysphagia. So you have to ask from the start because you are starting the GI from up. The first question, the mouth. Any mouth sores? You might have mouth sores. Any difficult swallowing? Yes, you might have it if candidiasis, for example. Again, immunocompromised patient. Any difficult swallowing, we finish it. Now, any acid brush or feeling acid taste because of GERD or any association. It's not significant, but it might be also there occasionally. Then the tummy question, any tummy distension, tummy pain, any change of your bowel habit, any coughing up blood and or blood through your back passage. What do you think is it important in this scenario? If the patient is having vomiting of blood, sorry, not coughing, vomiting of blood or blood through his back passage, is it important to ask?
maybe like ulcer,
Yes, any ulcer,
gastric ulcer
exactly.
or
Yes,
malignancy tumor.
or cancer, yes, lymphoma spreading to the GI, and there is also mass in the bowel.
yes, also
So
Dr.
give,
Dr.
yeah,
Bassem, a side effect of chemotherapy may decrease, may cause thrombocytopenia, neutropenia. So it should ask also. Yes.
yeah. These questions related to the relevant system. Then the
Mhm.
constitutional and the past history. He gave you a history of non-Hodgkin lymphoma. You didn't analyze it at all. You ask him since when only, and he give you some medication. You didn't ask about the last time, which is very important question. When it started And what's the last cycle of this medication, the chemotherapy? Are you compliant if he started for a long time? You have to ask all this question. Did you add any medication? This patient might have non-steroidal anti-inflammatory, for example, for pain, right? Any patient with cancer, he has pain. He might have the increase, or he might have added by himself over-counter medication, non-steroidal. Simply, he will have abdominal pain, he will vomit, and he will vomit blood as even, or melena, for example. And the case will be peptic ulcer. And it came before, right? So take care. The questions of medication list is very important. Not only to see the medication list. He is showing you the medication list for a clue in the case. Either some medication added or some medication would be the side effect of this medication. So don't ignore the medication. You didn't even ask about the medication names. Dr. Mahmoud are saying, I think he's the one offered you, right?
Yes.
Yeah, he didn't. You didn't ask Dr. Ala, what's the last cycle? What
I
are the
asked
medications?
I asked what medication
You
or
asked?
what treatment you are taking for this
Okay,
cancer, and he showed me the medication list.
Yes.
okay.
Yes.
But the last cycle you didn't ask when it
Yeah,
was?
no, that was
Yeah.
a big
Okay, it's a
yeah,
big
the
mistake,
last
really.
cycle, yeah, and the kidney, yes.
Yeah, not only the kidney, even it might be differential. You didn't think about differential diagnosis of drug-induced at all, which is the case here. Why? Because you didn't look at the medication list. Okay, so take care. Any patient will show you, or any surrogate will show you medication list means there is a clue in the medication. Even you can give him advice about a medication in the list. Please don't take this medication unless you seek or you sought medical advice. Why? Some medication might be the cause of your symptoms. For example, tummy pain and bleeding through the back passage or vomiting of blood. He might be, or it might be related to the non-steroidal, as I mentioned earlier. It might be the case, or it might be differential. So you can give him advice for the welfare. Don't take this medication by yourself. Okay? So take care whenever you ask about the medication. Surgical history important, allergy, all these things you have to ask. Hospitalization. Why this patient is having cancer? So he might be admitted earlier or prior to this presentation. He might take any medication, he might take or did any surgery or procedure. Be ready for all these things whenever you have patient with past medical history, significant past medical history like this, which is non-Hodgkin lymphoma. Okay, the next thing, the systemic review. You started good. You asked about the vision. You asked about feeling sick. Also feeling sick. One of the question for the GI. Okay, the vision. Why you ask about the vision? Because you thought there is increased intracranial pressure. The headache as well can lead to vomiting, as projectile vomiting. Then the other question for the semi-view, chest pain, awareness of heartbeat. You ask all these questions. Short of breath. I think the short of breath and chest symptom you didn't ask. Correct me if you ask.
Ask,
Then
ask,
yeah,
ask
okay.
Dr. Basim.
The system, the very important here in this scenario, the GI system, which is related directly to the diagnosis. The GI. Why you miss the GI? Because you ask about the muscle pain or joint pain. So you didn't ask the systemic review as a package. Again, my advice whenever you start to do any approach or any group, finish it as a package. If you start to do systemic review, finish it, then go to the, if you want constitutional symptom to be later, you can do it. But ask all questions together. Imagine the patient in front of you and ask him from head down to the toes. After the GI, the genitourinary. Always remember the system in this approach or in this order. Okay? The GI, the amount, of course, it will be reduced. The color will be dark because of the decreased amount. Maybe you might have blood as a side effect, maybe. But I think in this scenario, only reduced amount. The uremia symptoms here is very important as the decreased output. You can ask also about the compensation. Are you compensated with water intake or oral water? Then you are feeling confused also related to the uremia. And while doing examination, remember the uremia symptoms as the flapping tremors. So you will ask and you will examine. Why? Because it's important to have patient with decreased urine output. He might have either uremia or dehydration. You picked up the dehydration and you examine it, but you didn't examine the uremia signs and symptoms, or the signs and the symptoms in the history. Okay. The travel and family history you ask good. The travel, the HIV question here, you didn't ask about any HIV question. You have 3 minutes extra. This patient might have HIV. Any patient with lymphoma, you have to roll out the HIV, right? Do you think it's important?
Yeah, it may be important in the view of the lymphoma, but I think in the acute presentation, maybe it's not important.
Not in the acute, but you can put it as a differential. Not as acute.
Yeah.
Not as acute, but you have to address it if the patient is having risky habit. Okay. You might
Yeah.
have as welfare, the patient, for example, has HIV risk factor for either casual relationships. Whenever you have lymphoma patient, you have to rule out the HIV. Why? Because this patient on immunocompromised medication or immunosuppressant, and he might have HIV by any sexual or any other risky habits. Okay. Anyway, do you question you ask smoking and alcohol? And finally, the job. You didn't ask the job, right?
I ask it. I ask it.
You ask
Yeah.
what the job was. I forgot.
Teacher.
Is it
Teacher.
teacher? Okay. The impact also, don't forget it. Whenever you ask about the job, ask about the impact.
Yeah, I ask it also.
Okay. So the differential here, as already Dr. Mahmoud mentioned, it's clear for tumor lysis syndrome, acute kidney injury. You can say drug-induced because all and most of the chemotherapy can lead to GI upset.
Yes.
Or any medication, by the way, not only chemotherapy. Any medication, newly admission or newly administration, it might lead to a GI upset. Even the augmentin, any medication, you can say GI upset, one of the complication, early complication. Okay. But the good thing here, you ruled out the signs or the cause of increase in the cardiac pressure. Why? Because it's important. Such patient might have also brain mets or any headache related to the increase in the cardiac pressure. Again, it's brain mets, as you said, or lymphoma in the brain. Back to the your differential Addison, I don't think makes sense to mention the Addison in this scenario. Why? Because he just started the steroid 1 month back. Right? It should be for long term. And the patient, for example, missed a dose, or he took it for a long time and he did sudden abrupt of the dose. Right, Dr. Ala? Are you agree with this?
Yes, Dr. Basim. Actually, Dr. Basim, I was biased by another case. I think it came in Cairo also. This patient also was, I knew about this case recently.
Yeah.
This case also with a patient, he has cancer, but he has prostate cancer. And he was
Okay.
taking, he was in palliative treatment and he was taking corticosteroids. Okay,
Yes,
and the
yes.
same,
This is
yeah,
the
and the
problem
same,
when continue
yeah, and the same presentation also acute onset of
vomiting. But I guess
vomiting all over the
yeah,
night.
I guess
That's
the
why I was
steroid.
biased by it. And the clue in that case was the clue in that case was that the
He
patient
has
had recent
infection.
infection. Yeah,
Yes.
yeah,
Yes,
he has recent.
I know this case. It come to my friend Ahmed, Ahmed
Okay.
Mahanna, Ahmed Mahanna doctor. Okay, in this case, you should ask the patient.
The duration. How was
Yes,
the duration of the steroid?
how was the duration and when you stop, if you stop steroid recently, and how you stop the steroid. The patient will tell you, I stop corticosteroid by myself.
Okay.
So it is a
But I
Yes,
risk.
think
exactly. Yes, yeah.
I think it would be longer duration, not only 1 month
Yes,
or
yeah.
one session. Okay. So be careful. Don't always think about a case and don't distract yourself by thinking this is the case. You will miss the case. Okay, try to do the case as new case for you. Don't think this is the case. I heard about it in one center before. Yeah, it might be the case, but they are changing either the scenario or the onset or the diagnosis even. So always be careful and do the approach till the end. Try to pick up the finding, the most relevant differential, and to diagnose the patient well after that. Okay. Let's do the difference between rhabdomyolysis and tumor lysis syndrome. What's the major difference between both in the electrolyte? Dr. Ala.
Rhabdomyolysis, there will be
I think uric
also
acid.
hyperkalemia, and but there will be no hypocalcemia,
No, there is hypocalcemia.
rhabdomyolysis also hyperuricemia.
Uric acid, yes.
Both of them, they have the same electrolyte disturbance, but the phosphate will be different.
Yes, phosphate. Phosphate will increase the tumor lysis and decrease the
Exactly.
rhabdomyolysis. Yes, doctor.
Yes, tumor lysis hyperphosphatemia,
Yes.
and the rhabdomyolysis hypophosphatemia.
Hypophosphatemia.
Yeah, because the creatine kinase will combine with the phosphate. That's why you will have hypophosphatemia with rhabdomyolysis. However, in the tumor lysis, all electrolytes will be low. Apart from potassium, it will be high. Uric acid as well will be high. Okay. Any other question before moving to the next scenario? I think the questions are already covered. So uremia, of course, one of the investigation you should do. Don't forget the ECG. You might have pericarditis due to or uremia, as well as the creatinine, of course, the all electrolytes. And for the image, I think here you have to rule out acute intestinal obstruction as acute vomiting. And you examined the abdomen for the bowel sound, which is important to show the examiner that I examine it. Right? I think you examined the bowel.
Yes.
Yes, Dr.
Okay.
Basim.
Yes. Any question, Dr. Mahmoud or Dr. Ala?
Thank you, Dr. Basim.
السلام عليكم دكتور باسم.
Yes, عليكم السلام. Go ahead.
جزاكم الله خير دكتور محمود. شكرا جزيلا for very interesting case.
Thank you, Doctor.
دكتور محمود صراحة really very interesting case. But initially duration 2 days post chemotherapy is very confusing because to think of tumor lysis syndrome, initially tumor lysis syndrome can occur with or without chemotherapy.
Yes, doctor.
Yes, but the duration should be either 3 days before chemotherapy or 7 to 10 days post chemotherapy.
I think, Doctor, it is
وثاني
2 to 5 days. 2 to 5 days after the chemotherapy.
3 days. 3 days
Okay.
before chemotherapy and 7 days post chemotherapy. There is a
But as you said, yeah, the tumor itself, the type of the tumor itself, high burden cells. Yeah. So I think this is
yes. Yeah, I want to comment.
Exactly,
in each patient with hematological malignancy, especially in lymphoma, if the patient presents with vomiting, repeated vomiting with diarrhea or mostly cramp, plus renal impairment, we have to think of tumor lysis syndrome.
Exactly.
Any patient with electrolyte disturbance plus laboratory evidence of acute kidney injury or the patient present with oliguria, we have to think of tumor lysis syndrome.
Yes, Dr. Ahmed. So no matter of drugs. Okay.
Yes, even without medication.
Yes.
And as you said, electrolyte disturbance in tumor lysis syndrome, hypo only for calcium, hypocalcemia, plus hyper for 3, phosphate, uricemia, and potassium, KUB. And Dr. Basim, also electrolyte disturbance could be same mimic in tumor lysis syndrome and acute rhabdomyolysis. Same hypocalcemia initially, and then it will convert to hypercalcemia, plus hyperphosphatemia and hypouricemia. We can differentiate from the history after strenuous exercise or post-ictal condition. We will think of acute rhabdomyolysis. After cancer, we will think of tumor lysis syndrome. Moreover, we will differentiate by creatinine phosphokinase level. It will be very high in acute rhabdomyolysis, and it will be normal in tumor lysis syndrome.
Perfect. Yes. Thank you, Dr. Ahmed. Very nice comment.
Thank you so much. Really, it's very interesting case.
Yeah, thank you, Dr. Thank you. As Dr. Ahmed mentioned, the chemotherapy or the tumor kind itself might be the reason of tumor lysis in some cases. No need even to give you the chemotherapy as a past history. The duration, I agree. You might say 3 or 5 days, but I don't think it's something important they will ask about. Is it the first day? No, it might take some days, but you have to put them in the differential, either tumor lysis due to the cell lysis, or after the chemotherapy itself happened, the lysis happened or the cell turnover happened. The difference, yes, between both conditions, as Dr. Ahmed mentioned earlier, it might be similar, but later on would be hypo or hyperphosphatemia with rhabdomyolysis, and the hypophosphatemia with tumor lysis syndrome. Don't forget to involve the cardiologist for the ECG. You might have also ECG change related to the electrolyte disturbance, hyperkalemia change related, or the hypocalcemia related. Hypomagnesemia as well. All electrolytes will be low, apart from the potassium and phosphorus, according to the case. Any other comment? Thank you, Dr. Ahmed, again for your comment. Anyone want to comment before moving to the next scenario? Any question? Okay, let's do the next scenario. Dr. Mahmoud, can you post the scenario for Dr. or Dr. Ala? Can you post the scenario
Yes,
for
he posted already, Dr. Basim.
I put it already in the chat box.
Yeah, okay. Mrs. Sarah, 32 years old, came with breathlessness. Observation chart. Vital blood pressure 120/70, pulse 100/05, respiratory rate 26, 28, O2, saturation 90, temperature at 36.8. Okay, I will read the comments until Dr. Ala will be ready, or Dr. Mahmoud, sorry. Hypercalcemia, Dr. Al-Huda. I think hypocalcemia, not hypercalcemia. Side effect of chemotherapy, yes, it's very important. Thank you, Dr. Sarah. I think this is the case. Neutropenic sepsis, side effect of medication, yes, if there is hypotension, night fever, but you cannot judge on the case because he already has the same symptoms of infection. I mean, night sweats and fever. But the clue will be in the investigation. Or he had infection recently, like sore throat. He has urine symptoms, dysuria, or gastroenteritis. But you have to put it as a differential since you have hypotension or you have signs of dehydration and sepsis. Diabetes as side effect. Okay, I don't think we can put it as a differential. Yeah, diabetes side effect of the medication, steroid. But why I will say diabetes in the case? I didn't get it. Dr. Al-Huda, gastritis, pancreatitis, gastric lymphoma, gastric outlet obstruction, all this differential can be there. But why pancreatitis? Do you think the medication, chemotherapy related? And the tummy pain will be different, I think.
Yes, I think medication not cause pancreatitis. I think that.
Okay, you have to be sure about the medication side effects that can lead to the pancreatitis. Don't mention it unless it makes sense. Okay.
Doctor,
Yes, go ahead.
Sorry, doctor. In the history, the patient has upper abdominal pain.
Yes.
And I waiting for doctor to ask if he radiating to the back to think about the pancreatitis for many another cause.
I asked already, but he
Yes,
yeah,
he asked it goes to anywhere, but I tell him no.
told no.
Okay.
Okay, it's I guess the pancreatic pain will be in the middle, not epigastric. Epigastric means gastric or peptic ulcer or esophagitis. But mainly you have to about the radiation, and he asked about the radiation. Yeah, someone was asking, sorry.
And the description of pain intensity usually in
Yes.
pancreatitis is more severe, 7 plus. It will never be below 7.
Yes. And you have to ask, is it related to the food? And the position, of course, you can mention it. So the radiation, the timing, the position of the patient, relation to the timing of the food, all these questions can give you a clue about the pancreatitis or the mesenteric ischemia, for example, as a cause. Or intestinal obstruction, if you want to be also more wide in the differential. Okay.
I think the differential can be wide, but I think every case has its clue. As Dr. Mahmoud mentioned, the clue for this case, the recent chemotherapy and also
Yeah,
the low urine
exactly.
output.
Yes,
Yeah,
exactly.
and the
And
other
the
case that I
onset.
mentioned, yeah,
Mhm.
the other
Continue.
case that I mentioned, the missed dose of steroid and
yes.
or
And has
the
diarrhea.
fever.
Exactly. The onset will be different in both differential. So the acute onset will be having differential, and the chronic onset also will be another differential. Okay, you can put some similarity, but you cannot say say this is this differential for the acute can match the chronic, and the chronic cannot match unless there is acute on top of chronic. For example, chronic kidney injury or chronic kidney disease, and he has now decreased output suddenly, so you can say acute kidney injury on top of chronic. Acute pancreatitis with chronic pancreatitis. Some patient will have chronic pancreatitis presentation, and suddenly he has now severe abdominal pain. So you can say this is acute pancreatitis case. Okay, ready, Dr. Mahmoud? We can start?
Yes, doctor, I'm ready.
Okay, here you go.
Okay, good night. I'm Dr. Musa, doctor in the clinic today. Let me confirm you are Mrs. Sarah, 32 years old.
Yes, doctor.
Okay, Ms. Sarah, brought to my knowledge that you have shortness of breath. So could you tell me more about that, please?
Yes, doctor. Since yesterday I was washing the dishes, then I started to have this difficulty in breathing, and it was like persistent all over the night, doctor. I tried to take some inhalers of my husband, but it's not improving even. That's why I came today to the hospital.
Okay, it is the first time of having shortness of breath or any previous attack?
Yeah, this is the first time, doctor, yes.
So it happened, it has happened only at the night or
It happened
till
only
now?
yesterday, yes.
Okay, now you have shortness of breath?
Yes, doctor, yeah.
Okay. Do you have, do you think that anything worse in your condition, like you have may smell any pollens or dust or perfume?
No, doctor, I didn't notice.
Okay. Did you think that anything improve your condition other than inhaler?
I tried the inhalers, even the inhalers, doctor, didn't improve.
Didn't improve. Okay.
Yeah.
Okay. Do you have any? Do you have the shortness of breath awake you from sleep?
Actually, doctor, all over the night, I was this difficulty breathing. I couldn't sleep even all over the night. It's like intermittent sleep only.
Okay. Do you, any racing heart?
No.
Any chest? Do you have any chest pain?
Sorry?
Any chest pain?
Yes,
Chest pain.
doctor, I have.
You have chest
Yes,
pain?
yeah. Yeah.
Okay. Could you describe me the chest pain? Is this dull aching or stabbing?
Yes, yeah, it's like stabbing, yeah.
This stabbing. Okay. How much you give this pain? 1 is minimum and 10 is maximum. So how much you give this pain?
Like it's 4 to 5.
It is 4. Where is the site exactly of the chest pain? It is the middle or in the side?
No, in the side of my chest, like in the left side.
Does it move to anywhere?
No,
To your
doctor, no.
shoulder or your back?
No.
Okay. It is the first time you have this chest pain, yes?
Yes.
Okay. Do you have any cough?
No.
Any cough blood?
No.
Do you feel your chest is noisy?
No.
Okay, any long-standing disease should be aware?
No, doctor, I don't have any disease.
Any history of asthma?
No.
Okay. Okay, Mrs. Do you have any fever?
No, doctor.
Do you feel yourself tiredness?
No.
Any sweating?
No.
Anything? Anyone noticed that you are based than before?
No, doctor, no one mentioned like this.
Okay. Do you have any weather preference recently? You prefer hot weather or cold weather?
No.
Okay. Do you have any weight changes
No, doctor.
recently?
No.
Okay. 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 During this short suppress, do you feel yourself is dizzy?
Actually, no, but I'm feeling like I'm tired. I cannot breathe, but no
Okay.
dizzy.
Okay. Do you have any joint pain?
No, doctor.
Do you have any back pain?
No.
Do you notice any rash in your body?
No, doctor.
Okay. Do you have any weakness in your body? Weakness in your arms or your leg?
No.
Okay. Do you feel yourself unbalanced or unsteady?
No.
Do you feel any numbness in your body?
No, doctor.
Okay. Mrs. Sarah, do you have any tummy pain?
No.
Okay. Any acid, you feel heartburn or acid brush from your mouth?
No.
Any difficulty of swallowing?
No.
Okay. Do you have any sores in your mouth?
No.
Okay. Do you have any change in your motion, like constipation or loose
No,
motion?
doctor. No, it's
Okay. Very
okay.
good. Okay. Do you have any change in your motor work? Like
No, I didn't.
increase the amount of frequency or any exchange in the color?
No, doctor, it's normal.
It's not. Okay. Very good. Okay. Ms. Sarah, can I ask you a private question if you don't mind?
Okay, doctor.
Okay. Are you married?
Yes.
Okay. Do you have children?
No.
Any previous abortion?
Yes, doctor, I just lost my baby 6 months ago.
I am really sorry for that, Miss Sarah. Miss Sarah, which age or which week you lose your baby?
It was like 12 weeks, doctor.
12 weeks. Okay. Sorry for that, Miss Sarah. Miss Sarah, what about your period? Is it regular?
Yes, doctor, it's regular.
Do you take any birth control pills recently or in the
No.
past?
No, doctor. No.
Okay, very good. Okay, can I ask you a private question if you don't mind? Do you have any history of casual relationship?
No, doctor, no.
You have a stable partner, yes?
Yes, my husband, yes.
Okay. Do you have any history of blood transfusion, sharing needle, tattoo, piercing?
No.
Okay. Any history of travel recently, Ms. Sarah?
No, doctor.
Okay. Do you take any medication? Should be aware. Prescribed
No, I'm
or
not.
over the counter.
No, I'm not a regular medication, doctor.
Do you take any party drugs or illicit drugs?
No.
Okay. Do you have any family history of blood clot?
No, doctor.
Okay. Any past history of blood clot?
No, I don't know. Not aware of this.
Okay, Ms. Sarah, I would ask, what do you do for a living?
I'm a housewife, doctor.
Okay, how much is symptoms impact on your daily activity?
Yes, doctor, I couldn't sleep all over the night, as I mentioned you. It's very disturbing.
Sorry, Ms. Sarah, I would like to help you and diagnose you and give you proper treatment. Okay,
Thank you, doctor.
thanks, Ms. Sarah. Do you smoke?
Yes, doctor.
How many cigarettes and for how long?
It's like 20 to 30 cigarettes per day. I think it's like for 10 years now, doctor.
Okay, Ms. Sarah, I advise you to smoking because it may affect your health and your condition. So if you would like, I can refer you to smoking cessation clinic. if you don't mind. Okay, do you
Okay,
drink
I will think about it.
okay, do you drink alcohol, Miss Sarah?
No, doctor.
Okay, do you drive, Miss Sarah?
Yes.
Okay, I advise you to stop driving till now, and we will update you when you resume your driving. Is it okay?
Okay, doctor.
Okay, Miss Sarah. Do you have Miss Sarah? Can I examine you, please? Don't mind.
Okay.
Okay, first I will examine by the hand if there is any leukonia, any clubbing in your hands.
No, nothing.
Then I would also the pulse. The pulse, I think it is increased, and also I would like to examine the blood pressure, and also I want to see the observation chart of the patient. I want to measure the temperature and also the saturation. Then I would like yes, I would like go to the eye if there is any pallor, and the mouth for any central
No.
cyanosis. Okay, I
No.
will. Okay, I would like to look for GVB if there is any GVB elevated.
No.
Okay, then I will go to the lung to listen if there is any pericardial rub, any respiratory crepitation in the lung.
No.
Okay, then I will examine the heart, apex, and also B2. If B2 is elevated, sorry, palpable,
No.
and also I would like to examine the lower limb. Do you have any pain in your leg, Ms. Sarah?
Yes, doctor, I have pain in my leg since
Okay,
like 3 days.
3 days. Which
Yeah,
leg exactly?
in the right leg.
The right leg. Okay. Then what is the nature of the pain? It is dull aching, or
Yes, yeah.
stabbing? Mhm.
No, it's like dull aching pain.
Okay, I will see if there is any swelling in the limb. Also, I would like to measure
Swelling where?
swelling in the feet.
No feet swelling.
Okay, I will examine the leg. Which leg? Sorry, the left leg.
Right leg.
Right leg. I will examine the right leg to see if there is any hotness, any redness. See if there is any swelling. Then I would like to measure the circumference of the leg.
There is calf muscle swelling in the right lower limb.
Yes, I want to measure the calf muscle by the tab. I would ask for the tab and measure the calf muscle. It will be under the popliteal, 15 centimeters, I think. Okay. Then okay, Miss Sarah, what's your concern? Anything concerning you?
Yes, doctor. What's the cause of this breathlessness, doctor? Is it heart attack?
A heart attack is unlikely in your condition, Ms. Sarah. But what I concerning is a blood clottage in a blood channel of your lung. And I'm sorry to you that it is a serious condition if not treated. So what we are going to do now, we will admit you, and also I would like admit you and give you and we will do some investigation and some scans to your chest. Most probably this blood clot in your lung, it is related, and also blood clot in your leg. It is related to a condition named antiphospholipid syndrome. It is a disease of a problem in your defense system activity. So I will refer you to a group of doctor, like lung doctor, and also joint doctor, to make you a plan. So what do you think about that, Ms. Sarah?
So, doctor, it's curable condition. It's like this breathlessness can improve.
Yes, Ms. Sarah, I appreciate your concern. Your disease is not curable, but we can treat. It is treatable Can we, it's by giving you a blood thinning to dissolve the clot in your blood, in the blood channel in your lung and also to your leg. And then I will refer you to a blood doctor. He may give you a blood thinning for a period of time. So what do you think about that, Ms. Sarah?
2 minutes left.
Okay, okay, doctor.
Do you have any other concern?
No, doctor, no.
Okay, thank you, Ms. Sarah.
You want to examine something
you.
else?
I examined the hand, the blood pressure, saturation, lung, heart.
Okay,
the
the history. Any history you want to ask?
No, doctor.
Particular history?
I am satisfied, Dr. Bess.
Okay. Questions? So, can you start?
Okay, can you present your finding and the differential diagnosis?
Okay, I examined Mrs. Sarah, 32 years old. She has a complaint of shortness of breath since last night, and also she have chest pain. She have chest pain since yesterday also, which is stabbing in nature. Also, she feel tired. Mrs. Sarah have also leg pain, right leg pain, and leg pain. And he has a history of previous abortion in the first trimester. On examination, I couldn't appreciate any finding in the chest. Also, by examination of the right leg, there is
What findings you were searching in the chest?
I was finding in if there is any palpable P2, if there is any pericardial rub.
Pericardial rub in the chest?
In the heart, yes.
Chest examination?
Yes. Chest, I couldn't find anything.
You were searching for specific findings or?
In the chest?
Yeah.
In the chest, P2, palpable P2 about the coordination. In the chest.
Okay.
I don't know. I don't know.
Okay.
Okay. On examination, there is swelling in the right leg, and also increase the diameter of circumference of the right cuff. So I want to admit Miss Sarah. I have suspicions of pulmonary embolism. So my first diagnosis will be pulmonary embolism, maybe pneumothorax, another differential diagnosis. Maybe also, but I didn't. Okay, pneumothorax and also maybe pneumonia.
Okay.
Maybe pleurisy. That's my differential diagnosis.
Any other?
No, Dr. Alaa.
Okay. What's your investigations?
Okay, I will admit Miss Sarah. I would like to do a ABCD protocol, monitor saturation and the blood pressure and the pulse to the patient. And also I would like to do basic investigation, CBC, looking for any infection or any anemia. I would like also to do inflammatory markers if there is any signs of if there is any pneumonia. I would like to do also EPG and electrolytes and D-dimer. And about to confirm my diagnosis, it will be by CT pulmonary angio. Also, I would like to do duplex on the right leg to see if there is any DVT. Also, I would like to do echo and ECG.
Okay. And for the antiphospholipid syndrome?
Yes, anticardiolipin. Yes.
Okay. What's your management?
Yes, management. Also, I will after admission to the patient, I will measure the saturation and the blood pressure and give her oxygen. if there is any desaturation, and according to the cause, if there is any if there is a pulmonary embolism, it will be non-pharmacological. Patient education and counseling about his hair condition, and about hair condition about antiphospholipid, and also pharmacological by multidisciplinary team. It will be pulmonology and hematology, and also we need rheumatology to give her a proper plan. The treatment, it will be by anticoagulation if the patient is stable. If the patient hemodynamically unstable, if there is any decreased blood pressure, I will give here thrombolytic.
Okay, what anticoagulation you can give here?
Warfarin.
You start directly with the warfarin?
Sorry?
You will start directly with the warfarin?
No, I will start with low molecular weight heparin as a bridge to warfarin.
Okay, good.
Okay, thanks.
Thank you, Dr. Mahmoud.
Any other question you want to add?
No,
Okay.
thank you. It's
I
good.
will ask one question. What
Mhm.
other investigation you should add as a screening?
Yes, pulmonary function test. Screening EBG.
Okay, this is bedside test. Echo
Yes.
as well, bedside test. ECG, bedside test. No,
Yes.
something you have to do to screen for the confirmation of the disease.
Confirmation pulmonary embolism or DVT or antiphospholipid.
Why this patient is having antiphospholipid?
Yes.
Did you screen in the history and
Yes.
you want to do some investigation to confirm the primary or secondary?
Yes.
Okay, if you suspect secondary, what you should add to the screening?
I asked about joint pain, skin rash, back pain.
But still you will investigate, right?
Yes.
Okay, what investigation you should add?
صح. Yes, Dr. Basim. أنا أنكا أنتي دبل
Oh,
ستامبين.
okay, autoimmune screening, that's it. This is
Yes,
what I
Dr.
want you to say. Okay,
Yes,
autoimmune
yes.
screening.
Yes,
Okay,
Dr. Basim.
perfect. Okay, let's start the comment, Dr. Ala, please.
You did it very good, Dr. Mahmoud. Okay, you covered, I think, the whole scenario. You covered the differential diagnosis. You asked about the most probable differential diagnosis in such scenario. Only small comments like the patient came primarily with hypoxia. Her oxygen saturation in the observation chart was 90. I think it was more wise to offer oxygen supply in the first when you see the patient firstly. Okay, the other thing that you missed in the history is the family history. Okay, you didn't ask here about the family history. The patient has a
Minister blood clot.
ask about family history in general. Okay, the patient has a family history of heart attack. Okay, that's in her mother. That's why she was worried about the heart attack. Okay, I think other than this, you covered everything. I don't think the rule of stopping driving here is. I think no rule here for the driving, and also the an examination. Yeah, the MI. When examination, I asked about what you are searching in chest examination. You should search to exclude other causes of acute breathlessness, like pneumothorax, like pneumonia. Okay, I think other than this, the investigation, all the you mentioned, all the investigation that you mentioned, including also the D-dimer, okay, and the antiphospholipid syndrome, lupus anticoagulant, anti-cardiolepin antibody, and anti-beta-2 glycoprotein. And as you mentioned, also the Doppler, the CT, pulmonary angiography. But there was a question also for this case. This case, you will give here anticoagulant before, or you will wait for the imaging result. There was a question like this.
Yes, it is
What's your opinion?
What you will do, Dr. Mahmoud? Good question,
Yes.
by the way, Dr. Ala. What you will do?
Yes, I think this high probability
Probability, yes.
probability of pulmonary embolism. So I will
Why
give
you
it.
say, yeah, what you use to say this is high probability?
I think according to Will's score.
Perfect. So exactly, this is the
Yes.
answer.
Mhm.
Yes,
Dr.
yeah,
Rick,
exactly.
So you should do screening first or questionnaire of Wells score. Whenever
Yes.
it's more than 4, you will offer the anticoagulant, right?
Yes.
Okay. Any
Yes,
other
very well
questions?
done,
Dr.
Dr. Mahmoud.
Yes,
Thank
thank you.
Yeah,
you.
very well
Thank you,
done.
Dr. Ala. But I asked about travel, Dr. Bess.
You ask? Okay,
Yes.
I didn't. Sometimes I miss some points. Anyway,
Yeah, he asked about the travel also to exclude
Yes.
the risk
exactly.
factor of DVT. Yeah.
Yes, it's important to ask about it. To rule out any DVT because of travel as a trigger. I mean. Okay, let's comment. Good, really, very good, Dr. Mahmoud. You cover all the questions, but in the differential, I agree to put MI. Whenever you have acute presentation or acute onset complaint, you have to think about all possible causes of acute symptom. For example, in short of breath, and there is chest pain associated, you have to put MI, right?
Mhm.
MI, the patient of MI, how he will or she will present with short of breath. Is it wise to say this is possible? What do you
But
think?
I think it is unlikely, Dr. Besson, because
Okay,
in the
unlikely.
bottom,
Yes.
in the
Yeah,
bottom,
yeah.
because
But I'm
the
saying you have to rule it out and to
sure,
put it in the differential.
100%.
Okay, so what are the relation between short of breath and MI? How the patient might be presented? Or why the patient will be presented with short of breath? If MI, for example. And why I said MI is important.
Yes, maybe you mean RV, right myocardial infarction,
Or
right side,
or acute failure, heart failure.
acute failure, yes.
Right? Patient will be in acute, particularly the left side heart failure, pulmonary edema, and the patient will present with short of breath, although he was having chest pain. So
Yes.
it makes sense to say, yes, one of the possible differential, and I roll it out by asking about the nature of chest pain. It's not the chest pain of MI, but you have to mention it as differential. For me, it makes sense to say MI or ischemic heart disease as differential more wise than the pneumonia. Why? Because pneumonia will not present as acute.
Yes.
It would be for either subacute or chronic. Patient having the short of breath, but increase progressively recently. For any reason, for any type of pneumonia, the presentation will not be as acute. Or commonly, I mean, I'm talking about the commonly. Maybe there is some exception that like BCB pneumonia would be like acute presentation, but commonly they are presenting as a chronic course or subacute. Okay, back to the history. I think you covered the whole question in a good way, but I prefer to add to the systemic review for the systemic lupus and the connective tissue disease to ask about stiffness rather than the joint pain. Yeah, there is possibility to be joint pain, but ask more. Is there any stiffness in your joint? Why? Because it might be the case, SLE and secondary antiphospholipid syndrome. The other question, skin rash, you asked already. You can specify more rash to the face. Do you have any rash in the face or in the sun exposed area whenever you are going out? This is for SLE. Muscle pain as well, you can add back pain. And we already mentioned the joint pain. Dryness of the eye, there is possibility to have also association with Sjogren. All question and screening for connective tissue disease, you might ask in this scenario. You are not looking for the only presentation. You have to know why this patient is having antiphospholipid. Already you picked up the diagnosis, right? I think you caught it earlier because of PE. Or you just pick it up after the DVT sign, the leg pain, Dr. Mahmoud?
No, doctor, before I do
Before.
the yes.
Okay. So
I
you have
noticed
to
pulmonary
screen.
embolism.
Yeah, so you have to think and to screen about the possible secondary antiphospholipid syndrome. the SLE, the Sjogren, and you might even ask for the dryness in the private area of the mouth. Behsit
No,
as well, you can
no,
ask.
I asked about mouse sores. Yes.
Okay.
You know, Dr. Basim, I write the causes of pulmonary embolism in the site, and
Oh,
I put here this point in the structure
perfect.
to not
Perfect. That's why you ask about
distract.
the miscarriage.
Yes, I asked about miscarriage at the
Exactly.
end because the female history at the end.
Exactly. Yes.
So
All right.
I put this point in the structure.
That's why I don't have a big comment on you. The performance was good as usual. You catch the case and you ask good questions. Even the approach, you admit the patient. You have to admit the patient, of course. ABCD approach, and you have to offer vitals earlier. If there is hypotension, as you mentioned, and you suspect pulmonary embolism, you can do echo. If the patient is unstable, you might suspect pulmonary embolism due to right heart strain. Even you can offer the thrombolytic, right?
Yes.
Okay. The other thing, Wells criteria, whenever you suspect, you can apply Wells criteria, and you can even start anticoagulant after doing the D dimer. Or if you have suspicious of DVT, you can start anticoagulant immediately. Okay. So in this scenario, I think with previous miscarriage, you might add the anticoagulant from the start. Any question, Dr. Mahmoud or Dr. Ala?
Thank you, Dr.
Yes,
Basim.
and that's very good. Also, you asked the how many weeks during the pregnancy loss. But what do you think the relation, Dr. Mahmoud?
Because yes, antiphospholipid in the first trimester.
What?
I think it's yes. In the
Yes. Yeah,
first
yeah.
trimester, yes, you should ask.
The
Because
miscarriage
Yeah,
early.
yes,
Happen earlier.
because
Yes.
patient being miscarriage due to anything, due to trauma, anything.
yeah, but you should have also asked any previous also miscarriage before. This is her first time. So
Yes,
in antiphospholipid syndrome, either 3 abortions before 10 weeks or 1 or more abortion after 10 weeks. 3
Okay.
abortions before 10 weeks or 1 or 2 abortions after 10 weeks.
Perfect. Good question. Good note
Okay,
also.
that's why we are
Yes.
asking.
Okay, we have another case in PACES related to short of breath and delivery, not abortion, delivery. What is it, Dr. Mahmoud?
اسمها ايه cholesterol embolism.
No, no. Okay, one of the differential would be amniotic fluid embolism. But
Amniotic fluid embolism, yes.
okay, no, no. Another case, and it came in PACES commonly.
After delivery,
Yes.
she developed
Short of
pulmonary
breath.
embolism, shortness of
Not
breath.
pulmonary embolism, short of breath. Even patient cannot.
Yes, peripartum
Yes.
peripartum
Yes. Exactly. So you will have patient just delivered, and after delivery, maybe admitted to the ICU. After that, she went home and presented again with short of breath. Okay. So this is a case of peripartum cardiomyopathy. It came in PACES, by the way.
Yes.
But not as in the same scenario, because that patient will be having a trigger of exercise, cannot tolerate the exercise because of the heart failure. And she cannot lie flat. She uses mini pillows. So it will be different in presentation. This scenario, patient presented with short of breath along with the chest pain. So you suspect PE rather than suspecting heart failure. The onset, of course, also give you a clue of acute presentation. So PE here makes sense. Again, MI. So let's start in order. The differential diagnosis for this scenario. Pulmonary embolism on the top, of course. You can say as acute also. Pneumothorax. However, against that, you can say the nature of the pain and MI. For me, I will say this the third differential MI, or even you can say pleurisy, because here also the patient might have pleurisy due to, for example, SLE or connective tissue disease. However, the patient is again, the manifestation again is that. As Dr. Ala advise you, and this is general advice, any patient with pain scale more than 5, offer him painkiller. Any patient you notice in his chart saturation less than or equal to 90 or less than 94, and you will find him talking in distress way, like dyspneic. He will act like is dyspneic. The first thing to do, offer him an oxygen. Are you comfortable to continue this conversation, or you need some oxygen? Yes, please offer. You so you can call the nurse, or you can act like I'm offering oxygen for this patient. Okay, this is one of the welfare points. The same as the chest pain. If you are comfortable or you want painkiller, yes, please offer him painkiller. Okay, it will impress the examiner. Other question or comment from Dr. Mahmoud or Dr. Ala? Anyone has comment? Dr. Ala, Dr. Mahmoud, any question?
Thank you,
No,
Dr.
Dr.
Bassem.
Bassem,
Thank you
thank
very
you.
much, Jerry. Thank you.
Okay. Anyone with question? Okay, yeah, Dr. Al-Huda, perfect. Acute MR, one of the possible presentation. So patient MI started as MI and he has, for example, marital regurgitation. So again, it's left side heart failure and the patient will present with pulmonary edema. Be ready, all of you, pay attention always to the acute presentation symptoms or complaint. Nowadays, they are bringing two scenarios as long clinical consultation. One of them as chronic and the other as acute. So for example, you might have patient with acromegaly and the patient will be like this scenario, acute pulmonary embolism, chronic headache and acute chest pain, chronic GI upset, diarrhea, and acute abdominal pain. Okay, so be ready not only for the chronic course complaint, you can have also acute course, acute onset complaint. Okay. And be ready also to put differential of the acute presentation of anything. Headache as a chronic, headache as acute. Tummy pain as a chronic, tummy pain as acute. Chest pain as a chronic, chest pain as acute. Joint pain as a chronic, joint pain as acute. All this might be presented. Plus the constitutional symptoms complain. Fever or loss of weight or night sweat, for example, or jaundice or cough. Okay, all this might be the complaint. Anyone with question? Any comments? Please feel free to comment. I like when Dr. Islam. I thank you, Dr. Islam, for your comment earlier. Anyone has comment, and Dr. Ahmed as well. I want to hear the comments, not only as a verbal, not only as a written. I want to hear the comments. Anyone want to comment? Please add your comment.
Dr. Basim, Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
Thank you. As you said before, if the patient has a high probability of pulmonary embolism, initially we have, yes, if we think the patient has pulmonary embolism, we have to do D-dimer. If it's
Exactly.
negative, it's rule out pulmonary embolism. If it's positive, my colleague Dr. Mahmoud said modified Wells score. Yes, previously they are saying Wells score, but it's American. In British Society of Pulmonology or Cardiology, they are using exclusion criteria. It's named PERC criteria. PERC, pulmonary
Yes.
embolism exclusion criteria. It's
Yes.
same like PERC score, but each one of them, each item has a score of -1. If the patient has a score of 2 or more, immediately you will go for novel anticoagulant, DOAC. After that, we can perform for CT pulmonary angiography or ventilation perfusion scan according to preference or the patient's condition. It's not always a score. Modified, it's not Morse score, it's PERC score.
Yeah, PERC. Yeah, pulmonary
Yeah.
embolism ruling out criteria. You're right. Yes.
Yes, ruling out criteria. Yes.
BERC. Pulmonary embolism ruling
Yes.
out
Yes.
criteria. Perfect. Yeah,
Yeah.
more than two, you
Yeah.
have to start. Yes, exactly.
Yeah. Otherwise, the case was discussed perfectly. Thank you so much.
Okay, thank you, Dr. Ahmed. But what I know, I didn't hear examiner ask about this pair criteria. They always ask about Wells criteria. Anyway, get ready to for this question. By the way, Dr. Ahmed, in antiphospholipids, the NOAC or DOAC, direct anticoagulant, direct oral anticoagulant is not preferred one.
Yes.
Yeah,
So the choice would be
warfarin.
low molecular weight heparin if the patient
Exactly.
hemodynamically stable,
Yes,
or thrombolytic if the patient is hemodynamically unstable.
exactly.
I mean,
Yeah.
tissue plasminogen activator.
Yes, Dr. Ahmed, in exam, if you tell the examiner Berk score and not mention Wells score, he will minus you.
I will never use
Really?
ever use Wells score or PERC. I will say pulmonary embolism exclusion criteria.
Yes.
Yeah.
Okay, so
That's good.
better to say I will refer the patient to the pulmonologist and he will guide us either to start the anticoagulant or the patient is highly suspicious of PE or low probability.
Yes, it's better.
Yeah, but back to the anticoagulant. So you will start low molecular weight heparin as a bridge to the warfarin, but I think in the antiphospholipids, it's contraindicated to start the DOAC. No evidence that
Yes,
it can be started.
yes.
Yes. So you will
Yeah.
mention the low molecular weight unless there is kidney injury. You might start the unfractionated heparin. Again, bridge
Yes.
for the
And
warfarin.
in
Yeah,
case of
vitamin K.
antiphospholipid and also in case of stroke in patients with metallic valve.
Yeah, exactly.
Yes.
Valvular heart disease and antiphospholipid syndrome. It's contraindicated to start the DOAC. Yes. Okay, thank you, Dr. Ahmed, for your comment again. Anyone with other comments? Any question? Can you repeat the investigation, Dr. Samah? The autoimmune. Autoimmune part, you can grossly saying autoimmune screening. That's enough in this case. And he will ask you what the importance of doing that. So you will say, I want to roll out the secondary antiphospholipid syndrome or antibody syndrome. If he asks you what are the autoimmune screening, now you can do from starting from the non-specific, like anti-nuclear antibody. It's non-specific, just screening. The rheumatoid factor as well. All this screening as non-specific. The time for specific, every condition, you have specific investigation. For example, SLE, you will say anti-Smith, anti-smooth muscle, antibody, anti-double strain antibody, right? For the rheumatoid factor, you can say anti-CCP. For the Jugran, you can say anti-Ro, anti-La. For what else? Polymyositis, anti-Jo. Systemic sclerosis is anti-centromere and anti-scleroderma 70, according to the type. So you have a lot of investigation, but grossly you can say autoimmune screening just to know is it secondary or primary. I hope it's clear, Dr. Sama. Okay, most welcome. Any other questions?
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. Yes.
الله يديك العافية. دكتور
كلها.
باسم, can I put also as acute presentation of chest pain, can I put aortic dissection also is a differential diagnosis? And also I have to exclude trauma.
Trauma, okay, you can ask in the history, but you cannot put as a differential. They want the medical causes. And you have a lot of medical causes. So even myositis, you can say it. Myositis, the patient will present also with chest pain with short of breath. The myositis pain, like pleurisy pain, the patient will have chest pain and the short of breath while taking breath, right? Or with this inspiration. So we might put it as a differential. But whenever you want to put differential, say what against. The aortic dissection, what against the aortic dissection, Dr. Nahla? I will ask you. Or the examiner will tell you why aortic dissection and what against
From the
aortic
start,
dissection.
from the start, the type of the pain and the radiation of the pain.
So you can put it, okay, because this is another cause of acute
Exclude
presentation.
serious.
Okay, but it will not be short of breath. Here, the main
Yes.
complaint is short of breath. Okay, but if you want, you can say it, and you can say against that the patient is not having tearing chest pain, which is not radiated to the back, and this is not the criteria of aortic dissection, or he doesn't have the criteria of aortic dissection pain. Okay. But here in this scenario, it's not matching with the case because the patient mainly presented with short of breath, not chest pain. I am saying the causes or the differential of short of breath along with chest pain. So again, let's repeat them. Pulmonary embolism, yes, the patient will present with chest pain along with short of breath. The MI, patient will present with chest pain along with short of breath. The pleurisy, the patient will present with chest pain along with short of breath, right? If you want to add myositis, also makes sense. And myositis, yes, as I said, myositis as differential also can be, but aortic dissection, it's difficult to say he's having short of breath.
Excuse me, Dr. Basim.
Yes.
We can add also pneumothorax.
Yeah,
I think
pneumothorax,
it is
yes.
higher than pleurisy
Yes.
because she has a risk factor. She is a smoker, and COB can cause only shortness of breath, but not chest pain. So just as a smoking, we can put pneumothorax as secondary
Yes.
pneumothorax.
Yes, you're right. So the pneumothorax. Anyway, you have 5 causes of short of breath and chest pain: pneumothorax, pulmonary embolism, MI, and heart failure together, pleurisy, and myositis. Put it as a differential before going inside the station. And according to the presentation and the manifestation, either to narrow or to spot on some one of them, or just remove one of them as a differential and put the one makes sense on the top and the less likely at the bottom. I hope it's clear now.
Yes, clear. Thank you.
Oh, okay. Okay, thank you. Pneumonia, I don't think pneumonia matching the differential here. Yes, you can say it as a chronic differential, but as acute, I don't think the pneumonia makes sense because this patient just yesterday presented with the short of breath. So you have to put the acute causes of short of breath or acute causes of chest pain. Pneumonia will be like 7 days, I'm having short of breath, or they will write for you the patient presented with short of breath for the last 1 week or 2 weeks, even months. Okay. Or you can say it only if you have BCB pneumonia, because the patient might present with acute presentation with exercise, for example, and it might be complicated with pneumothorax, as all of you know. Okay, thank you too, Dr. Abdul Malik. Any other questions?
Yes, Dr. Basim, I have question.
Yeah.
About driving in this patient.
Yeah. Oh, good to ask.
Mm.
Okay, if you are raising the issue and you suspect it is related directly or indirectly, you can ask the patient, are you suffering while driving? If you feel that the question doesn't make sense. But if not, don't ask why the patient with short of breath will not drive, for example, or why you stop him driving.
Yes.
The short of breath itself, I don't think. Maybe the chest pain. The patient is having severe chest pain. He cannot even sit on the seat. Otherwise, it's not important to ask, do you smoke, do you drive in this question, in this
Yes.
scenario.
But
So,
by
yeah.
by general pneumothorax, stop driving,
No, it's flying only.
flying and hiking, and okay.
Yes. The driving, as I mentioned before, driving issue related to the vision or related to the position, like ankylosing, or procedure or surgery, all over the bases. Otherwise, don't ask unless you feel it's indirect way, like knee pain, Charcot joint. Yes, the patient
Yes.
might have difficulty to feel the feet while driving, and he will be having an accident. Okay,
Yes,
sensory loss, for example. Otherwise, I don't think you can ask it. Or if you ask it by mistake, you can correct your question like, do you feel it's related or it's affecting your driving? No, doctor, so ignore it. If you ask the question by mistake, like you are asking in package, do you smoke, do you drink alcohol, do you drive? Oh, I asked this question by mistake. So you can ask him, is it, do you think it's affected your driving? He will tell you, no, doctor, of course, no. Why So no need to stop driving at all. Just make it as you are screening, but without advising. Okay?
Mm.
Any other question, Dr. Mahmoud?
Thank you, Dr. Basim. Thank you very much.
Okay, most welcome. Anyone with other question before ending the session? Okay. Thank you, Dr. Mahmoud, Dr. Ala. Everyone shared the session today. Attend, interact. See you tomorrow, inshallah, with the convocation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Mahmoud.